Thank you, Mr. Chairperson. Ladies and gentlemen, it is my great privilege to be an invited speaker in this joint session. This is my disclosure information. Today's topic is dementia. It is a geriatric disease that everyone fears the most. The most common cause of dementia is Alzheimer's disease, followed by post-stroke vascular dementia. Typically, approximately 25% of all ischemic stroke are associated with atrial fibrillation. Large-scale epidemiologic studies show consistently significant association between atrial fibrillation and cognitive dysfunction or dementia. Cognitive dysfunction usually accompanies 30 to 40% of AF patients. And AF causes circulatory stasis, hypercoagulable state, endothelial injury, resulting in brain ischemia, inflammation, and neurohormone changes which affect cognitive function. Since today's topic is AF rhythm control, I will mainly cover cognitive dysfunction caused by brain hypoperfusion. There are sufficient epidemiologic evidences that OAC, oral anticoagulants, reduces dementia in patients with atrial fibrillation. Freiberg reported that the longer period of OAC use in AF patients, the significantly lowered the incidence of dementia. In our group, the incidence of Alzheimer's disease and vascular dementia were higher in Korean AF population, but we demonstrated that the use of OAC significantly lowered these incidence of rates. The mechanism of dementia in atrial fibrillation patients include embolic events, macro bleeding, and rhythm-related hypoperfusion. In particular, irregular rhythm causes decreased cardiac output due to varying stroke volume and mental fog. And brain hypoperfusion inhibits flow-mediated vasodilation and endothelial function and causes oxidative stress, mitochondrial failure, eventually neuronal cell death. This is RAFA's trial. RAFA's trial is a randomized clinical trial comparing the effectiveness of early rhythm control in patients with acute stroke, conducted in 4 major centers in Korea. In patients with acute stroke and atrial fibrillation, we compare the immediate rhythm control strategy versus usual care strategy that delays rhythm control at least for 2 months. AF rhythm control started with entrance withdrawal, followed by cardioversion and catheter ablation. As a result, even though there was no difference in 30-month outcome, but the stroke recurrence rate was significantly lower in early rhythm control group in the 12-month outcome. So this study has established the clinical evidence that the earlier AF rhythm control can reduce stroke recurrence rate in patients with acute stroke. A follow-up study is ongoing to compare the cognitive function. Brain perfusion and cognitive function are interrelated. This is a Rotterdam study. It demonstrated that the reduced cerebral blood flow measured using the phase contrast MRI was associated with accelerated cognitive decline. Gada-Dotter performed the brain perfusion scan before and after cardioversion. A successful cardioversion patient visibly showed a significant increase in brain perfusion compared to the patient who failed rhythm control after cardioversion. Daeun Kim and our team analyzed the effect of AF rhythm control on dementia in over 400,000 AF patients. AF rhythm control significantly lowered the incidence of both all-cause dementia and stroke-free dementia. In particular, when comparing the effects of rhythm control versus rate control on dementia, the dementia risk was significantly lower in the rhythm control group under the age of 80. So in AF under the age of 80, rhythm control has a positive effects on cognitive function. Now, let's look at the clinical utility of AF of catheter ablation. We all know that the Cabana trial proved the superiority of mortality in cardiovascular hospitalization of AF ablation over medical therapy, and Castle AF and Castle HTX trials shows the overall mortality benefit of AF ablation in heart failure patients with atrial fibrillation. AF ablation also reduced the risk of stroke up to the level of a non-AF population compared to medical therapy alone. And it also improves the 5-year follow-up renal function than medical therapy in Korean database. In 2011, Bunche investigated dementia incidence in over 37,000 patients over 3-year follow-up. Among these, approximately 4,200 received the AF catheter ablation, and the incidence of dementia was significantly lower compared to the AF patient group without ablation or non-AF population. This positive effect of AF ablation was maintained for 3 years. The incidence of dementia, not only vascular dementia, but also senile dementia and Alzheimer's dementia were significantly lower in AF ablation. However, pathophysiological relationship between AF ablation and Alzheimer's has been questioned. Accordingly, we evaluated the causal association between atrial fibrillation and dementia using Mendelian randomization. Mendelian randomization is a powerful technique to evaluate the mechanistic association using genetic polymorphism. But this study did not look at the effect of AF catheter ablation, but simply looked at the causal relationship between AF and dementia by cause. We performed the MR analysis using 34 AF-associated SNPs targeting 0.3 million population registered in UK Biobank, and the results showed a significant causal association of AF in non-Alzheimer, non-vascular dementia. However, in case of Alzheimer, we did not see any causal association with atrial fibrillation. The Karman's group paper in 2013 was their first report on the effects of AF ablation on cognitive function. In this study, it was rather shocking that the cognitive function decreased immediately and 90 days after catheter ablation. In particular, the proportion of cognitive dysfunction after persistent AF was significantly higher, and subclinical silent cerebral lesion occurred in 7 to 14%. However, our group evaluated cognitive function MoCA test after AF ablation with a longer period of a 1-year follow-up and 3 times higher number of patients. Contrary to the previous report, AF ablation group showed significantly improved cognitive function at 1 year after ablation, but the medical therapy group reduced the MoCA score after 1 year. And this positive effect on cognitive function after ablation disappeared in patients with recurrence of sustained atrial fibrillation after the procedure. This result reflects positive effects of maintaining sinus rhythm by improving brain perfusion. We studied the effect of AF ablation on cognitive function using National Health Registry data in a larger population, and Daeun Kim demonstrated that the AF ablation significantly reduced the overall dementia risk compared to medical therapy. And this dementia reducing effect of AF ablation was not limited to the patient with history of stroke, but was equally effective in non-vascular patients. Last year, Kalman Group announced the result of a randomized clinical trial on AF ablation and cognitive function. Somewhat different from their 2013 study, they followed up the patient for 12 months, and there was no cognitive dysfunction at all in the ablation group. It's 0%. Rather, 14% of ablation group showed a cognitive function improvement, showing results consistent with our study. However, it has been reported that the procedure was long ablation time or an independent risk factor for new onset cognitive dysfunction. Lastly, I will conclude this lecture by focusing on the effects of efforts to avoid silent cerebral lesion during AF ablation procedure. A silent cerebral lesion is a benign brain MRI lesion that disappears after several months without affecting neurologic or cognitive function. Nevertheless, we should avoid this silent cerebral lesion because they are procedure-related microemboli events. And Harbert recommended the following in his review article. He recommends an irrigated tip RF catheter and shorter LA indwelling time. Withdrawal and reinsertion of cryoballoon catheter should be avoided. We have to avoid ablation and mapping catheter exchange as much as possible when we use single transseptal approach. And it is recommended that the cardioversion be postponed until 4 weeks after the procedure. Of course, uninterrupted OAC and ACT level over 300 during the procedure are required. So in conclusion, ladies and gentlemen, embolic events, microbleed, and rhythm-related brain hypoperfusion induce the cognitive dysfunction in 30 to 40% of patients with atrial fibrillation. Oral anticoagulation reduces the incidence of dementia in AF population. AF rhythm control protects cognitive function under 80 years old population. AF ablation improves the cognitive function by improving cerebral perfusion. Long ablation time is associated with new onset cognitive dysfunction after ablation. And silent cerebral lesions are transient, but we must reduce the risk during the procedure. Thank you very much for your attention.